Good afternoon. I'm Francisco Moreno, and it's my pleasure to introduce the speakers for Grand Rounds this afternoon. Welcome to our psychiatry Grand Rounds, and we're nearing the end of the year, so a couple of good, strong talks to finish up the year on a good note. And I'll be brief as I introduce the speakers, because I know they have a lot of material today, and we also want to be mindful of the time that we're up our conversation. A couple of Steves coming our way. It's a pleasure to introduce Dr. Stephen Goldberg. Dr. Stephen Goldberg is president of Correctional Mental Health Services, a subsidiary of ConMed Healthcare Management, Inc. And Dr. Goldberg got his undergraduate training at the University of Florida, and then got his MD from the University of Colorado, and I think did residency and fellowship in forensic psychiatry at the University of Maryland. He has had an extensive career working in forensic and correctional psychiatry, holding different positions, and most importantly as president and founder of Correctional Mental Health Services. He also has had a number of appointments in education at the University of Maryland, at Johns Hopkins University, and at Walter Reed Hospital as well. We also have a good friend returning back to join us today. They'll be tag teaming today, Dr. Steve Galper. And Dr. Steve Galper has had his undergraduate degree in psychology from the University of Washington, an MBA from the University of Michigan, his law degree from the University of Arizona, his MD from the University of Arizona, and then he was our pilot resident in the joint psychiatry and neurology residency program here a number of years back. And not only did he finish both neurology and psychiatry combined program, but then he went on to do a fellowship in pain management program. And Steve Galper has been a master of all trades, not just a person that tries it for a little bit, but has been working also in a number of settings here in town, doing inpatient emergency consultation, now working at a forensic unit at the Pima County Jail as well. And so without taking more time, please help me welcome them both as they talk to us today about psychiatric care in a correctional setting. Thank you very much, Steve and Stephen.
Good afternoon, everybody. Thank you for that very nice introduction. Today, I promise not to go past 6 o'clock. I know time is an issue here, and I'll be mindful of that. The goal today, really, I hope that everyone here leaves with just a little more awareness of what's going on in the jail system here and what differentiates treating people in the jail versus the community. Hopefully, you'll learn some things you haven't heard before, and we'll try to end early enough to answer any questions that you may have. There are several learning objectives that I would go through if we had the time, but I really would like to get to the meat of the lecture. If anyone has any questions, I understand there's handouts so that you can look at the objectives. But I want to point out, number one, with the 48 hours of risk when people come into a jail. It really is critical when people are being arrested and taken into a jail setting to assess them for safety and to be able to determine what needs to happen to keep them safe. And managing people in the jail is really what we do. And you'll hear a lot about that today. Oops. Okay. So we're just going to get to the meat of the lecture here and get in there. So Alcatraz Prison in California. This is not what we're going to be talking about. Okay? We don't treat people in prisons, we treat people in jails. And the first question that people have is, well, what is the difference? Well, there's a lot of differences. In a jail, typically people are in a jail for less than 1 year and are going to be pre-trial, meaning not yet convicted of a crime, innocent until proven guilty, still in effect in Arizona, isn't it? Yeah, okay, I just want to make sure. And short sentences so that someone who gets in trouble for, maybe not paying child support or something, CDS or controlled dangerous substance charge, typically would get out in less than a year and would serve their time in a jail. In a prison, you're talking about typically longer than 1 year, and everybody who's there is post-conviction, meaning that they've already been through their trial, they've already been found guilty of a crime, and now they are serving their time. The differences are tremendous in the types of services that you provide and the management of the two different facilities. When you have someone coming from the street, you're essentially running an ER. You have people coming in intoxicated, you have people going through withdrawal, you have unmedicated schizophrenics, you have people who want to be schizophrenic because they just got arrested, and you have to kind of sort through all of this. The acuity, the rapid turnover, management and safety, that's really the two pieces that you're going to hear over and over again. In the prison setting, you get people who are coming from the jail. They've already been stabilized. Dr. Galper has already treated them. They're already feeling better. Or they've already been determined that they don't have an illness and that they have an Axis 2 issue rather than an Axis 1 issue. So it changes how you approach them and what you do. Now, violence in jails is what everyone worries about, what everyone thinks about. Anyone has seen Oz on HBO has this image of how dangerous jails are. And as I said, that has nothing to do with the jail system. And typically, jails are much safer places than people think. Don't get me wrong, I'm not suggesting that you go and visit for any length of time, but you don't have the length of time in the facility to establish gangs inside, to have this type of connection where contraband could get in on a regular basis. It certainly still comes in and does that. But violence still happens. And what happens with our patients, the mentally ill people, is that they have a terrible reputation. The stigma associated with mental illness, I'm sure you've all, seen that and have dealt with that in the community. In a jail setting, it's amplified. And the violence is what people are worried about. Mentally ill inmates are more likely to be in a fight, hit, or punch somebody. The mentally ill inmates are almost 2 times as likely to be in 2 or more fights. And 25% of mentally ill inmates are charged with breaking jail rules. So the management of this population in the jail is not just about treatment in a vacuum. It's treatment in a setting where you have custodial staff, the security staff who are there 24/7, and you have people who are going back to a dormitory type situation where they very much are on their own, and even though they're being watched constantly on the camera, there's still the risk of fights and these types of things that could happen. So the impact of mental illness for those who are in the jail. Again, I'm going to give you just some quick stats. I'm not going to drown you with all these statistics, but I find it very interesting that current or past violent offense, 25% more likely than the general population. 3 or more prior offenses, 30% more likely. Substance abuse problems, 43% more likely, and we're already talking about a level that's pretty high to begin with. Now, this is the one that usually gets people's attention. 300% more likely, 3 times as likely to be the victim of past abuse. So issues related to trauma and trauma-informed care and helping the officers understand that how you approach an inmate/patient changes dramatically their response. And being aware of these things and helping them understand that they don't have to be a tree hugger, or the term that people say is a hug-a-thug, or, you don't have to want to help them, but you certainly want to go home safe. And the vast majority of correctional officers that I've come across are actually decent people trying to do the right thing, and they're trained and they have certifications and they take their job very seriously. So if we could help them manage their population better, keep them safer, and be able to provide better care for our patients, then it's a win-win situation. Daily management, daily jail management, how people get through their day. It's all about the routine. At Pima County Adult Detention Center Complex today, I believe they have approximately 1,400 inmates. They do not have 1,400 correctional officers. And so usually one correctional officer is managing a large group of people at any one time. So somebody violating jail rules or being involved in a fight or verbal assaults is going to have a dramatic impact on their daily management. And you could see without the proper education, without the proper management of our patients, then there is going to be this stigma and this approach that really doesn't give our patients a fair chance. And they get put in seclusion, and they get marginalized to one section of the jail, or they're more likely to violate the rules and lose their good time. Mentally ill people are more likely to complete their sentence than any other group of people. So it's because they don't get the good time, they don't get the good credits, no one's in a hurry to get them out. So suicide in jails, this is why they care, okay? It's a lot of reasons why they care, but when it really comes down to it, safety and being able to effectively manage this population and get treatment to those who need it are our bread and butter. There's a lot of scary statistics about jail suicides, 3 to 8 times more likely to happen than in the general population. You're talking about inmates, and I said adults, committing it between midnight and 6 a.m., as you might expect, because it's the least staffed period of time. You have suicides often occur 2 to 3 days after the incarceration. That first 48 to 72 hours is critical. In terms of inmates processed, you're talking about a jail like Pima County that has almost 1,400 inmates, at times as high as 1,800. You're talking about 40, 50,000 intakes a year going through there. So you are processing people in and out. People are pre-trial, they can get bailed out, they can get, they can get and get out, and so you have to treat them all as though they're going to stay. And what do you do with them? You can't put everybody on suicide watch, although I'd like to. You just can't. And as you would expect, the most likely form of death in suicide is hanging, and cutting is the second most. And just like in the general population, women are more likely to attempt, men are more likely to succeed. So in a jail setting, we have to find some way to manage risk. How are we going to look at this person and determine he goes to suicide watch and he doesn't? And just a quick note about suicide watch in a jail for anybody who's in an ER or who's in a hospital or in an outpatient clinic who knows that someone's going to jail and you recommend suicide watch, well, just put them on suicide watch and then we could discharge them. We don't have to admit them. And a lot of times that's the appropriate thing to do. But suicide watch generally means you're in a cell about the size of where I am right here to the wall behind me. You're generally stripped naked and given a suicide gown, which is a hard burlap-like tunic that can't be tied into a knot. And that's where you stay. And it is not comfortable. It could be very cold, but it's safe. And there are those people who need it, and those people who just are trying to play games, but we don't, we treat it like the word bomb in an airport. I tell people, when I still do assessments and treat people in the jails, and I'll see someone on suicide watch, and what happened? I say, well, I was just kidding. So, well, we have a terrible sense of humor here. It's like, okay, and then generally I'll tell people, you get one oops. I'm like, what do you mean? Well, you got arrested, you thought you were going to go to the hospital if you said you were suicidal, oops. You didn't want to move from this housing unit to another housing unit, so you said you were suicidal, oops. And generally we'll give people one oops because, they need to learn. But unfortunately, as time goes on, people use the word suicide to manipulate the situation. You can't do this because I'll be suicidal, and that type of splitting with custody staff. If Dr. Galper didn't give me my medicine. If I had my medicine, I wouldn't be acting like a jerk, and now it's his fault, not my fault. All of these kinds of things that are going on. So we have to really look at the risk factors and go through them very carefully, and then reassess and manage. And when in doubt, someone's going to stay on suicide watch a longer period of time. And in that circumstance, when I described that somebody using it to manipulate, then we can't differentiate that from someone who's chronically suicidal. We don't have the resources or the ability to, we don't have a test yet, as far as I know, that can determine who's being honest and who isn't. So we have to treat everybody in the same way, and unfortunately that means extended period of times on suicide watch. They get the care, everything that they need to be safe, just not as comfortable as they want to be. So, as you would imagine, the risk factors for suicide are like they are in the general population. Previous attempts to harm themselves, the #1 risk factor. Also, what people don't always appreciate is violence. is a risk factor for suicide, because suicide is just violence turned inward. So you think about the population that's coming into a jail, and you think about mental illness because they may not be able to get their meds, or there may be substance abuse going on as well, and now they have a violent history, and now they're alone in the cell at night and going, I just lost my job, or I'm going to lose my home, or I don't have this relationship anymore. She's going to leave me for doing this. You could imagine that every one of these things could be pretty overwhelming, and when left alone in the first night or second night trying to handle that burden, sometimes it could be overwhelming. So you can't stop someone from killing themselves. I wish I could. I've never been able to figure out how. However, you can prevent and delay someone from killing themselves. And if you could do that, and you get past that first 48, 72 hours, most times you're going to make a dramatic impact on what happens. So this is the group that we look at, as well as other factors, and we're trying in a very short period of time to try to do that. So when we talk about the mentally ill in jails, and as was mentioned, I'm part of a company that provides services nationwide, and so I get experiences in the Northwest, in the middle of the country, down here in Arizona, in the Mid-Atlantic, and it's impressive how many communities are struggling with budgets, and what's happening to the community mental health systems are just getting gutted. Hospitals have less and less resources to admit people, and where do they wind up? With us, unfortunately. So in mid-year 2007, 780,581 inmates in local jails, not prisons. These are local jails. The increase is steadily going up. You talk about the number of jail inmates per 100,000. That's the way we try to compare a small jail to a large jail, or try to compare regions by using this to normalize it. And the increase from 193 to 259, and from 95 to 2007. Now, that's a huge increase in the percentages that we're talking about. The jails are not empty. Most of them are operating at 96 or greater, and most of the jails I see, they've got people double bunked, and they're sleeping on what they call sleds in the hallways of the units, and so it can get quite, very much like a pressure cooker. And what we've already talked about, you can see that really stressing an individual to the brink. Unfortunately, hospital beds, and I have several slides that I could have shown that, it's a really cool one. It has hospital beds decreasing and prison beds and jail beds increasing at the same time. I don't know how we figured out that that's the way to manage our mentally ill population, and clearly something needs to be done. But in the meantime, they still have to be treated, and we still have to approach this population. And my hope today is to introduce a little more information to you, and maybe get you to realize that in jails, it's not just the doctor who couldn't get a job, or the nurse who just got her license back and is on probation. We have good quality people trying to do good work, and in a very limited resource environment, and physical plants aren't always exactly designed. Particularly, you get any jails that are older than 10 years old, they weren't thinking about this level of management within the jails. So the demographics: blacks were 3 times more likely than Hispanics, and 5 times more likely than whites to be in jail. 9 out of 10 inmates are males, which is why I refer to them as men most of the time. No offense to the women in the audience. You guys are bad too, so I don't want you to leave you out. Now, this is a stat that I think gets misused quite a bit. 64% of jail inmates have a mental health problem. Now, this is an illness and or symptoms. 64%. Again, how do you start distinguishing who needs treatment, who doesn't? You can't just give medicine to everyone comes in. You can't just do that. Dr. Galper will talk a little more about the management and the treatment issue. But when you do the math and you start looking at it, and you look at how many inmates are in the country, and you multiply this times that 64%, you're talking about 500,000 incarcerated people with either mental illness or symptoms of a mental illness. Pima County, when they were up to 1,900 inmates, over 1,200 people in that building that you drive by and look at are in there with mental illness. Just think about that, the magnitude of that problem and what is necessary to manage them. You have in your audience our mental health coordinator from Pima County, who is responsible for monitoring all of these performance indicators and audit standards and things like that. So again, I'm going to end it quite soon and try to let Dr. Galper get up and continue. But if you think about the DSM-IV diagnosis of a mental illness, and you try explaining this to a correctional officer of 20 years, so yes, it's a clinically significant behavioral or psychological problem. It's really very, very serious, and associated with present distress or disability, with significantly increased risk of suffering death, pain, disability, or important loss of freedom. And they look at you like, well, everybody. Okay? Well, yeah. And then you have to say, well, but it can't just be because they have deviant behavior or they're conflicts that are primarily between the individual and society. Okay, well, that's everybody here. So you're saying they all have an illness or none of them have an illness? Well, yes. Okay, and that we have to help them understand. And what happens is, and perhaps anyone who's treated somebody in the community who comes in and says, my meds were changed, or they didn't give me my medicine, or something like that, we have to manage the jail. And that means if we see somebody who was diagnosed with a mental illness while actively using for 10 years straight and has been on 3 different antidepressants, none of which were ever stopped, they were just added, and they're on Seroquel for sleep, and they're on this medicine for bipolar disorder, and we don't know what is going on, and it turns out they get clean for a couple of days or a couple of weeks, and suddenly they don't have the illness. And so being able to manage that population and help the correctional officers realize that we know the difference between a real illness and one that isn't real, and then they become empowered, they start having trust in us, and now they're saying, hey, this guy's staying in the corner and eating out of the garbage and not showering, I think you need to see him. Or, hey, doc, this guy, after he left you with tears in his eyes, he went and gave a high five to his buddy and just beat him in chess. So these are the kinds of things that we rely upon, and that relationship is critical. So I love the cartoons because really that's what you come here for. And generally, the point is not everyone who comes to see us really needs treatment. So I'm going to quickly go through some of these statistics. 54% report symptoms of mania. 30% symptoms of depression. You would think it would be 100%. And 24%, 1/4 of the population have reported symptoms of psychosis. What are you supposed to do with that group? Is it methamphetamine? Is it withdrawal? Is it true schizophrenia? It really becomes interesting and to manage. So you look at psychosis in the general population in terms of some symptom of psychosis, it's about 3%. You get into the federal prison arena, it's now at 10%. You get to the state prisons, you're now at 15%. And then you get to the local jails, and there's the 24%. So you look at how this gets selected for and what happens. And generally, the people with psychosis and the schizophrenics are getting in trouble, but not going to federal or state prison as often as they're going to jails. We are the new mental health community. And it's a huge public health concern. I see some nodding and people recognizing this. Is this really the way we want to treat our mentally ill? Is this really what we're trying to do? Now, as a forensic psychiatrist and as someone who's worked in a state hospital and someone who's been in jails, I can tell you that the vast majority of the people I see are the same people you see. There's no difference. They're just not admitting to you when they come into the ER or to your clinic, hey, I just got out of jail. Generally, it's, oh, I've been away for a while, I was off my meds, and I'm back. And so we don't always know, but they're the same people. They really are. So the management versus treatment is really what we talk about and what we teach all the time. This is what we have to do. We have to differentiate. And we can't treat everybody who just wants treatment or who might benefit from treatment. But everybody, and I want to stress that point, everybody who needs treatment to be safely managed gets it. And you could see that difference, and hopefully it makes some sense in terms of how to approach this problem with the limited resources that there are. But you could imagine that people who might benefit from treatment, who want treatment, might not be happy with this approach to care. So there's challenges that we have, and I'm going to get to this point that not everyone, again, who comes to us is in, really in need of treatment, but maybe just a little pat on the back and a little education. So on this, I'm going to turn it over to Dr. Galper, and thank you for your attention.
So what I'd like to talk about then is to pick this up as what we're doing in management. So when you think about the goals of treatment in the jail, that first, what we're really going for is safety. What I'm really trying to do is to lead the team that are doing mental health, both the mental health professionals, the mid-level practitioners, the other psychiatrists, myself, in concert with custody to make sure that the entire milieu remains safe. So it's the safety of the inmates, the safety of the staff, and whoever else happens to be in the facility. So the way that I do that is we start out with systematic screening. So what we do is as they come through intake, that they're evaluated first by EMTs. We try to collect as much data as possible, and that basically as we get more data that we're able to get people where they need to be through the intake system, and the people that have the flags of mental illness then tend to do more and more, there's more and more depth to their psychiatric evaluation. So we want to make sure that they have adequate access. That's why there is a myriad of professionals that are in the jail, both starting out with techs. We've got mental health people at the bachelor's and master's level. People are licensed mental health professionals. We have licensed substance abuse professionals there. So we try to target the kind of services that people need in the facility. Individualized treatment going along with who they're being treated by. And one of the things that certainly that I need to be able to do is to make sure that people are getting the treatment that will be able to be transferred back into the community. And I'll talk more about this, but I think in the community it's certainly acceptable and at times excellent use of medications to go off-label, whether it's using an atypical antipsychotic for sleep or using an Wellbutrin, for example, for ADD, even though they're not FDA approved. In a facility where you're really worried about the milieu of the entire facility, this becomes problematic, because if my cellmate is getting Seroquel for sleep, I want Seroquel. And it becomes there is a jail regimen that is what the patients would like as opposed to what they need. And it's certainly what we try to do is make sure that people are treated properly and that their symptoms are being treated, but at the same time to use a dopamine agonist, which is Wellbutrin for the residents, as a primary antidepressant is certainly problematic. Using an atypical antipsychotic with all of the metabolic issues as a sleep medication is also problematic, and I'll talk more about that. I want to minimize introduction of contraband into the jail. That's partially is the psychiatric medications, because, and we'll talk about this a little bit more, is that it becomes currency for the patients to use to get commissary so that they can get the regular food. What they do is they sell these pills to their friends. That's where they get money for the commissary. And then finally, release planning. I don't say discharge planning because I need to remind myself that although certainly people are being discharged from hospitals, they're being released from jail. And I think it's important for people in the community to realize I don't get to hold somebody just because I am the most narcissistic doctor in Tucson and believe my treatment is better than anyone else. When the judge says they get to leave, for some reason they just don't want to continue to have me as their physician. I don't understand, and they want out. And they have 2 hours to get out, so I can't hold them, and that's a huge deal. So long before, as soon as I know that somebody's on their way back into the community, we have liaisons to contact COPE or Kodak or La Frontera and let them know what's going on. We're trying to get much more proactive about giving them the medication regimen that they're on. Standards of care. First, I certainly want to follow what's going on in the community. I practice in this community. I have a private practice in the community. And I want to take that information and certainly what I've learned in the community hospitals and the way I practice in my private practice and apply that to the jail as much as I can, given the constraints of the jail. I want to make sure I follow the National Commission of Correctional Health. This is like JACO for jails. We're getting ready to be audited now. I can tell you that everybody gets a little bit uptight and a little bit of anxiety. We haven't gotten to the point of having to put Xanax out for anyone yet, but certainly people are worried about passing this audit, and we will because we follow these patterns, which helps us standardize the care. and then again the American Correctional Association, and then the American Psychiatric Association. So again, there are standards to be followed, and we follow those standards. So we want to practice the best medicine that we can in the facility. So how do I do that? I use multidisciplinary care. That means, again, it's just not the treatment that the psychiatrists are providing, but it starts right with the mental health professionals to the substance abuse counselors. It's all of the people that are in mental health, in addition to the medical people. Part of the advantage of being trained at the university here and having had the opportunity to not only go through the psychiatry residency, but neurology as well as a year of anesthesiology, is to be able to curbside and be able to be available to the medical people so that they have continuity of care. So everyone's involved with patient care at the jail. We try not to have a strict separation, but making sure that the care is seamless. Comprehensive therapeutic approach. Again, what I'm certainly more, I think, in the facility than even in my private practice is that I'm really trying to give people the tools they need to be able to deal with, for example, anxiety is a common complaint. And certainly what I tell them is that we can give you and teach you tools so that you'll be able to manage your anxiety without taking Xanax every 30 minutes the entire time you're in the jail. So it's a matter of getting people off medications, getting them to realize what's going on, what's happening inside of them, as much as they're able to tolerate, depending on where they're at, and then giving them those tools. The interdisciplinary approach, again, it's not just mental health, it's medical, and it's mostly custody, because remember, we're in a facility that people are in a correctional setting, and the eyes and ears of the custody staff is incredibly important. They'll tell you if the behavior of the patient, and they are my patients, they're the inmates of the facility, they're my patients. And they'll tell me if my patients are acting differently when I leave the facility. This morning, 6:30 in the morning, patient comes in, I'm booking him in, he's telling me, well, I take Adderall and Xanax. Well, amphetamines and benzodiazepines are not real high on my list of drugs to use in the facility for all of the obvious reasons. And I said, well, I'm not going to be able to do that for you. I leave, and 30 minutes later he's acting out. We have to have somebody go in. He said the magic words, as Dr. Goldberg was saying, I'm suicidal, and he found himself in one of those smocks. So again, if you're suicidal, whether you are or you're just using that term, we're going to keep you safe. And patients learn quickly that there's consequences for their behavior when they're in this setting. And one of the things that the custody says that I certainly think is important is they have on the floor, it says firm, fair, and consistent. And what I really like about that more than anything else as a psychiatrist is being consistent. And I try to provide consistent care across the range of all of the patients that I have a chance to see. The mental health clinicians, they get to teach the therapeutic goals to the custody staff, try to round off some of the edges of the custody people that may be a little bit harsher than we think that the mental health patient should be treated. And at the same time, we're being trained by custody so that we learn more about jail culture, something that I certainly wasn't aware of a year ago, and training and engagement with the treatment staff. If a year ago when I started as the director of mental health in the jail, I had no idea that Wellbutrin and Seroquel were drugs of abuse. My attitude was, if you think you need an atypical antipsychotic, by God, I'm going to give it to you. My experience about behavior and how patients do has certainly changed, because in the environment that I am able to treat patients in now, I'm able to see how they are when they're not using any street drugs, when I know they're adherent to therapy because the custody staff is watching them take their pills and everything is closely monitored. It's amazing how much better people are doing when they're not self-medicating on the street with alcohol and street drugs. Because unfortunately, because of cash constraints in the community, Cope, Kodak, and La Frontera can't afford to drug test people every time they come in for an appointment. But when I have them in the facility, I'm able to see how they do without substances that I'm not prescribing. So my strategy pharmacologically is I'm generally using exactly the same techniques. I start out with the same principle of drug selections that I use in my private practice. Then I have to recognize that there are drugs that have value to the inmates beyond what it may do to help them with their psychiatric symptoms. So if something's contraband, I'm going to be very careful about its use. One of the things I want to be very clear about is there are no drugs that are banned at the jail. I have the ability, as well as every other psychiatrist and prescriber, to use every medication that's available in the formulary that's for sale. But I certainly try to use that in a way that does not create more hazards for other patients or for the staff. The variability, I mean, I'm certainly looking at, since I'm in a controlled setting, and now I'm able to control for substance abuse, I can see how patients are doing with their particular regimen. It's interesting to me that nobody that was able to sleep in the community, when I do sleep observation studies, which we order often, they become basically small kitty cats because they're sleeping about 18 hours a day. And what's happening is because they're always laying on their bunk and they're always in and out of sleep. So it's not that they are sleeping soundly 18 hours, but because they have poor sleep hygiene, that once I can have one of the mental health people give them some of the training and tell them some of the things that they can do even in their cells or while they're in day room to be able to stay awake, that their sleep tends to get better and it has more of a circadian rhythm to it. You know, it's interesting that there's no definitive efficacy with atypicals over typicals. They're certainly more effective for negative symptoms as well as side effects, but when you're using some of the typicals, that they are as effective for the positive signs of psychosis. And I think that's important to remember. Although certainly Clozaril, which I'm not able to use because of the requirement that I get blood tests every week, that's certainly not true. That would be the gold standard. And in the community where you have the ability to draw blood every week with those patients that are adherent, that certainly is the way to go. What you really need to watch for is in the adverse effects that patients are going to have, and using typicals versus atypicals. Again, you can individualize the treatment, and that you could use the medications that are most effective because you're able to control for the environment and control the other substances that they're getting. So some of the challenges, inaccurate diagnoses. I think certainly what I want to make sure when people come in, you know, when I was a resident back in the days of the giants, I was the last of the giants. Anybody who graduated after me then is in the days of the demi-giants. So the issue becomes that malingering and factitious disorders have risen in my differential diagnosis the longer than I'm in the facility. I always want to make sure, first of all, as someone who has had the privilege of being trained in neurology, that I don't miss something medical, for example, on somebody that's confused. And then I want to make sure, so after I have them neurologically and medically clear, I have to tell you that I want to make sure I get the psychiatric diagnosis, and while I'm thinking about that, I go, what's the benefit to the patient behaving in this manner? Because it's important to recognize that there's tremendous secondary gain in the facility. It may just be people have this amazing ability to swallow things before, never had that before, because they get to have a field trip over to Northwest Hospital or over to Keno. There are people that all of a sudden start cutting. You have to recognize that some of these behaviors have a benefit to the patient in a correctional facility that it doesn't have in the community. Secondary gain we talked about. The impact of substance abuse. I think for me, having the ability to control to a great extent that people are not using substances really lets me take a fresh look at a therapeutic regimen, both pharmacologically and non-pharmacologically. When the number of patients that I have coming in They are incredibly sophisticated. I saw a patient 2 days ago. He says he alternates between buprenorphine and heroin because he knows when he can't get the heroin and starts to withdraw, he can use the buprenorphine to hold off his withdrawal, the signs of withdrawal and the feelings of withdrawal, and then at the same time, he'll wait long enough for the buprenorphine to wear off, that's Suboxone and Subutex, and then he'll start using heroin again when he has the ability to pay for it. That level of sophistication shows that people know how, at a level of the patient treating themselves or using the meds, how to use these. So by being able to start fresh, you really get a chance to see how people are responding to a therapeutic regimen. Polypharmacy, by being in a controlled environment, I get to start over. So for people that are on an alcohol detox protocol or an opiate detox protocol, I'm going to hold their psych meds until 7 days and they're off the protocol, and then I get to start over. I get to see them, or one of the other prescribers will see them, and we'll get them restarted on their medications depending on what their symptoms are now that they're off of the substance and they've gone through the detox. Off-label usage, just touching on that again, I minimize that because it's the safety of the facility. Because again, it'll spread like wildfire if people have medications that have value. It's an issue of safety. There are patients that are vulnerable to being bullied to get their meds. There are patients that are willing to attempt to get the medications from those that are weaker. It's the idea that you're creating an environment that's unsafe for the staff that has to work with the patients, because in a pod, it's not where everybody's in a cell and the staff, the custody staff, is behind like a glass panel. They're out in the open. I think that the way that the jail is run here at Pima County is quite progressive about the fact that the custody staff really circulates on the pods with the inmates. And I think that's really an important difference than back in the 40s, 50s, and 60s when there was this solid separation. Being told to move on. Diversion, suicide, and black market. Again, wanting to make sure that people don't hoard. I don't want them to commit suicide. It happens once in a while. And certainly I don't want them using it for the cost. This is a picture of LA County Jail. In 20,000 inmates, if this jail was in Arizona, it would probably be the 5th or 6th largest town in the state. And people would still have to prove they were not immigrants. This is San Quentin. Again, we're not talking about prisons here, so you see the difference in the size. In California, they're having problems. If you want to know problems, here's the problem. This is Maricopa County. If you really want to know who's not JACO or NCHC approved, just go up and talk to Sheriff Arpaio. He's costing the state millions of dollars because he runs the jail in a way that may be politically astute on the right, but it certainly isn't treating the patients, and it's not keeping people in the milieu safe. There's been millions of dollars of lawsuits and judgments against Maricopa County because of the jail there. I was in South Africa recently, got to see Robben Island. This is a place you don't want to be. Nelson Mandela was there for 27 years. He may be the only person that goes right from prison right to be president. I have a thought on this. I'm holding since one of my colleagues is here, I'm not going to say anything against Republicans. So acute agitation, I want to go real quick. Potential harm to self or other, impacts on jail management, again, the way that acute agitation gets managed. Some of the causes, the psychiatric issues when people really are psychotic, behavioral, people are trying to get their place in the jail in the pecking order of either the inmates or trying to show how tough they are. Again, this is one of the problems of agitation, and certainly environmental, that there are certainly times in the intake area, as Dr. Goldberg was saying, in that first 48 hours when people come in, that environment, they have to be careful that they think there may be some reason for them to be agitated, in the sense they may be able to get to the hospital instead of being booked into the jail. So the responses, we want to intervene immediately. in terms of what I do psychopharmacologically, if I can get people to take PO meds, I will. If they'll take it orally, I think that's great. If I need to go to injectables, I will, because I don't have to worry about informed consent in this situation where somebody's a danger to themselves or a danger to others. So what I'll do is, for me, I mean, I was trained by Dr. Moreno and some of the people here that had a lot of experience on the acute units. I'm still a Benadryl, Haldol, and Ativan kind of guy. Find it to be very effective. The orally disintegrating tablets are great, but if they won't take POs, they're going to spit out those tablets. I have not found them to be that effective. So, what are the challenges with non-compliance? You have decompensation, persistent symptoms. What I'm trying to do is I'm trying to get people to, certainly to get a therapeutic relationship so that I can keep them from decompensating. I want to make sure that these symptoms are treated so that, again, I have a milieu that's safe for the entire facility. And also, what happens is the mentally ill tend to spend more time in jail because they're not as quick to get bonded out. They're not as quick to get released on their own recognizance. And if I can get their symptoms under control, I can help them to get back into the community, because I don't have the community people and their mental health, the overtaxed community mental health people going, you know, we're hard to handle this guy. Why don't you see if you can keep him here longer? What I'm really trying to do is get them in a position to be transferred back into the community as quickly as possible. Impact on jail management. The more that I'm able to control the milieu, that people are doing well, the more programming that can be done, the more programming those patients can be involved in, and that there's less of the administrative segregation problems that occur when they're not controlled. Again, causes, side effects of medication. I want to make sure that when people are medicated, they're not getting thrown into mania or they're not becoming lethargic. If they're poor responders, I need to make sure I get that adjusted. Again, I don't have to worry about substance abuse. Lack of insight, I want to try to get a therapeutic alliance with the patients. I don't testify in court. I'm not a Rule 11 kind of guy. When people talk to me, I go, I'm not going to testify in your case. I'm here to treat you, because a lot of the patients are worried that I'm going to take what they tell me and it's going to end up in their case. I go, don't talk about your case. Let's talk about how you feel. Let's talk about how you're responding to the meds. How can I make this as tolerable as I can for you? And also cultural beliefs, the way that Native Americans versus Hispanics versus African Americans, everyone has preconceived notions about how things work in the jail before they get there. They bring that culture. I never worry when I don't have a Native American look me in the eye. I don't expect it. It's a sign that with disrespect. I want to respect where people are coming from when they come in so I can build that therapeutic alliance. I try to take the patients where I find them and build on that relationship. So assessment of reasons for non-adherence by the patients. Again, building the therapeutic alliance. I want to make sure that I don't have people that are having anticholinergic effects from whatever drugs I happen to be using. Pharmacologic modification as I need to. One of the great things is, I can tell you, for those of you in private practice, my patients always show up. I never have to worry about where they are, and my no-show rate is 0. That makes my administrator very happy. So the issue is I can see them when I need to make sure that the medications, that they're moving in the right direction. Certainly, I want to give them education at the level that they're able to understand it. And IM injections, you know, when all else fails, if I have to get a PAD petition under Title 36, I do that in the facility. I don't send people to Keno. I actually have the ability in the facility to do a PAD petition and get people on meds involuntarily if that's what it takes. And finally, witness drug ingestion. The COs are watching. That's a good thing. I know that the people are taking their meds. If they attempt to cheek or they're going to divert the meds, I stop them. I wait 14 days. I reassess. I want to make sure people understand if they're cheeking the meds, do they really need them? And I want to give them that opportunity to either show me that they need the meds or to understand that they may not need them and they may be able to cope with this controlled environment without the medication. Informed consent. We have, every time patients come in, I certainly give them the risks and benefits of the medications so that they know why they're taking, what to expect. In an acute decompensation situation, obviously, depending on the level of the emergency, I may not have to worry about that as much. Again, it's the same statute, but I do, remember, nobody takes medication against if they don't want to in the jail if there's no petition. So, this is not, it's not the gulag that Solzhenitsyn talked about. So we go through the process the same as we go through in the community if we need to. Danger to themselves, other inmates, or staff. Basically, again, the Title 36 petition, those of you that are involved in the Title 36 process, if they are getting out of the jail, if they're being released and I don't think they're safe, we do an emergency petition. They go directly to Keno Hospital for evaluation. If they're going to be staying in the jail for a while, what I'll do is a PAD petition. I don't treat them. I encourage them to take orals while we're waiting, but then when we have the petition process done, if I need to start with IM medication, I will. And then the medication and selection alternatives, again, it's a combination of best practices in the community with combined with the fact that we're in a correctional setting, watching it to make sure that I'm also aware of how the milieu of the facility is. So again, some of the things that are not medications that I use, and I want to sort of go through these quick to sort of put them up. So again, this is what the mental health people are doing. This is the multidisciplinary approach. You can read this. But the education piece is really incredibly important, more important than I am, more important than the meds, because they'll take that with them. So we really stress how to handle these factors that tend to get patients in problems. So hopefully they don't just keep running in and out of the system, but we're able to break that cycle and get them so that they stay in the community and not having to come back. I think it's really important at the bottom that between the custody staff and the mental health people to have new patients that are in the jail understand the norms. Like, you really don't want to be talking about what your cellmate is doing to the CO. It's really unhealthy. And it's important for people to understand that. And we try to give them that kind of education. So again, very respectful towards the patients while they're there. I think that if you would see and have to watch the interactions, I think the words sir and ma'am are used much more between COs, which are the correctional officers, and docs and the patients than it certainly is in the community. I try to get people motivated. Look, this is how I can help you get out of here faster. I try to give them problem-solving skills, not only while they're in the facility, but after they're released and back into the community. The communication, wanting to be clear about what the expectations are, and improving cognitive distortions, both if they are psychotic, treating that, and then if they're not psychotic, but they either have a factitious disorder or they're malingering, acknowledging how they are feeling, acknowledging what they tell me they're experiencing, and helping them to get to a place where they are in the same reality that I'm in. Hopefully that's the real one. Again, this is a picture of the Pima County Adult Detention Complex. There's a capacity of about 2,000 people. Again, interestingly, because of funding that is decreased, that it's now running about 1,400. It's a friendly game of the basketball, challenges to treatment. I want to go through these again quickly because I really want you to have time to ask a couple of questions. So housing, again, making sure that people are in the right place while they're there. If you have any questions about this, there are 2 units that I actually have responsibility for more beds than, for example, Sonora Behavioral Health Hospital. Between the acute unit and the step-down unit, there are administrative segregation units that we round on very frequently. This is where patients don't have mental health, specific mental health diagnoses, but because of their behavior, we still want to make sure that we're seeing them and that they're doing as well as they can do. And avoidance of lockdown, we try to avoid that. And again, access to care issue, I always point out only the inmates in a correctional setting have a constitutional right to health care under the 8th Amendment of the Constitution. The rest of us are on our own. It's important to make sure that we have a physical plant that is appropriate for treatment. We have excellent staffing right now at the jail, and that people are appropriately trained, because we have to meet all of the guidelines that are available both by the NC, the correctional facility itself, as well as the credentialing. And the cultural issues, again, we really work hard on cultural competence and making sure that when people are being seen, that that's part of the picture. It's a multidisciplinary issue. It's a multidisciplinary issue for treatment, as well as making sure that when we talk about suicide risk, which is very important, that that also enters into the equation. Patients that are from some cultures being much quieter than patients from others, that'll let us know well in advance when things are going wrong. And certainly try to minimizing the use of medical language, giving written information when appropriate in the proper language. For example, all information given to inmates is certainly available in Spanish here. Techniques for assessment of diverse cultural background, that's for training for the mental health professionals, and addressing treatment expectations and adherence in a cultural manner, so that depending on what particular culture that patient identifies with, self-identifies with, that we're able to meet them on their own terms. It provides the best possible milieu, and it certainly gets to the issue of what the etiology of their mental illness is. And medical liability issues, again, you take a look at the slide, you've got this in the handout. I think practicing the best medicine is certainly going to minimize the risk for the patients, for the staff of the facility, as well as the physicians in terms of medical malpractice, the biggest problems being suicide, as well as what goes on when people are put into restraints. These are future directions, which will have to be for another talk because of the time, but just definitely I want to use practices that are consistent, using a proper algorithm, and then certainly then taking it to the next step of individualizing that is important, recognizing that in the jail that we're frontline providers of mental health services, and the better that I get to control the environment and the milieu, the better health the better environment I have for people to be able to improve with their mental health issues. So in summary, again, wanting to make sure that we're providing the best care and best practices, and continuity of care is very important as people go back into the community. And then here it is, oh my God, did everyone else jump off the cliff? What am I going to do? And what we don't want to do in the jail is just keep jumping. So we're trying to stop the patients from doing that. Thanks a lot for your attention. And Dr. Goldberg and I can take questions.
Does anybody have any questions? Yes, in the back.
So, I run the consult liaison service here in the hospital, and every once in a while we get a person in the emergency department who's in custody. They're going to jail, but they get brought to the ED because they need to get stitched up or something because they were in an altercation. They're suicidal or psychotic or whatever, and they call us to assess, and we know they're going to jail. How do we make sure that they get adequate mental health follow-up at the jail? How can we alert you to let you know that this person is voicing suicidal ideation?
Well, I can tell you that one of the best things to do, that if it's possible, and I don't always know if this is possible, if you can send a packet with them, and with the police, to have the police drop the packet off with the intake people, that really is the way that we know that they came from for example, University Hospital and what happened in the emergency room. Certainly, everybody in here should have my cell phone number, and the standard line is it's 1-800-I-DON'T-CARE, but the real number is 444-2462. All the professionals have it. I certainly have no problem with a physician or either an attending or a resident calling me up and go, hey, this person's coming over, just want you to know this is what we found. We sent a packet. That'll help us. I can tell you we're going to try to get medical records. I think UPH, just like everyone else, we sometimes don't get them right away, but we'll get them eventually. But if you want to give me a heads up, I'm always happy to take that heads up. But the packet is really important. If you can put a packet together, that will really help.
For those of you who didn't hear, our mental health coordinator is here, and he suggested that we'll make a fax number available as well, so it'll be a confidential fax, and that may be another way to get that information to us.
The fax comes into medical records, so there's no HIPAA issues.
Okay, and that's 24/7. Okay.
I saw some other hands. Any other questions?
Substance abuse, at Pima County General, you mentioned you know that they're not using or whatnot. Are you testing?
I have the ability to test, and I think, certainly the environment at the jail, thankfully, is not on HBO, and there isn't people having like a bucket of hooch underneath with the apples and the pears. That certainly, the big reason for that is the turnover is so much quicker than it is in a prison that people don't get to develop the ability to do that. Is there some substance abuse? I'm sure there is. Do I test for it? When I believe that it's appropriate and somebody comes in and they look and they have a certain way of acting, when I have a clinical suspicion, I have the ability to get a test. But I think what really is different is that the access is so much more limited than it is certainly in the community, that it doesn't come up often once people are there for a week.
If I could just, the bigger problem that we have is the iatrogenic substance abuse and what we give. And you'd be surprised, Dr. Galper mentioned earlier that he didn't think that Wellbutrin and Seroquel were contraband, but they crush Wellbutrin and snort it. And when we looked at it, suddenly we were looking at our own numbers, and we realized that the percentage of people on Wellbutrin were going through the roof. And it's something like, wow, you don't want Seroquel anymore because we know that's abused, and now Wellbutrin is the new drug of choice, and I have ADHD, I have ADD, I have depression, nothing else works for me but this, and all of these things, and we have to be very careful to watch that and monitor that. And Dr. Galper and I were just talking over the last 2 days about how you think you're on top of it, and then suddenly you look at the numbers and go, how did we get this many people on Wellbutrin in such a small place? And then you realize, oh, there's a new line, there's a new way. So the substance abuse is much more of a concern about what we give them versus what they bring in.
Just to give you an idea, shame on me. When the population of the jail was 1,500, I did a spot check and there were 530 people on Wellbutrin. What am I doing? So certainly that's something that I really need to look at, because in the community, as you all know, Wellbutrin is not the frontline medication for depression. It's an SSRI, but why is it in the jail? It's a dopamine agonist. Well, found out. So that's what's happening, and certainly what I want to address.
The international name for Wellbutrin.
What was that, I'm sorry?
Amphetamine.
Okay.
How appropriate.
Yes, sir.
On the few suicides that occur, where do some occur? In the mental health unit or in the rest of the jail?
Well, Peter County is unique in that they actually have a mental health unit. The vast majority of jails that my company works in, and the ones that I've visited, and it's literally been hundreds over the years, I'm embarrassed to admit, of 17 years of doing this, is that most of them occur in the general population. And generally it's the person that you know nothing about, who's never had an issue, who got a call from their girlfriend and said, not only am I leaving you, you have no house to come back to, and I cleared out your bank account, and by the way, your kid doesn't want to talk to you anymore, have a nice day. And that's 11 o'clock at night, and they have to go through the night alone, and that's generally what happens. Well, you've been a great audience. Thank you for your attention. We're sorry we kept you late, and have a great day.